So it is my privilege now to introduce a friend of mine, Dr. Michael Liu. I met Dr. Liu about 10 years ago. About 10 years ago when I worked for the Department of State Health Services and was meeting with other state health officers from the southern part of the United States, we came to a frank realization that birth outcomes were very different in the southern part of the United States than the rest of the nation. And we asked then Director of HRSA, Mary Wakefield, how can the federal government help us in addressing this issue? And she introduced us to Michael Liu, who was our right-hand person, our leader, that really brought us together to figure out how we could bring team science, collaboration, innovation, and improvement in order to improve the health status of mothers and babies in the southern part of the United States. You have his full biography in his background, as you have for all speakers. If I was to simplify this, he is an excellent clinician, having practiced at UCLA as an obstetrician gynecologist. He was a researcher really looking at health equity and how do we address that. He was then tapped in the Obama administration to come and lead the maternal and child health initiatives of HRSA nationwide, and from that received a lot of accolades and a lot of recognition for the great work that he did looking at home visiting and other innovative ways to improve the health of mothers and babies and children across the nation. After serving in the federal government, he went back to academia, working at Georgetown first, and now is the dean of the School of Public Health in California at Berkeley, and is doing tremendous work there. I think you'll find him to be an extremely passionate, committed, and I'd also say a very humble servant who is working hard to improve the lives of moms and babies and children, continues to do this work. It touches me every time you talk, Dr. Liu, of how your family and how this touches your family. And he's a father committed to making sure he raises his daughters and make sure that they are successful. And so it really is my pleasure to introduce my friend, a mentor, a colleague, Dr. Michael Liu.
Good morning, Texas. It's great to be back in Texas. I was a keynote speaker here about 5 years ago. At that time, I talked about our national strategy for infant mortality under the Obama administration. That was about 5 years ago, and a lot of things changed in the last 5 years. I moved from DC back to California, where the weather is milder, politically speaking and otherwise. I moved out of federal government into academia, so I guess I get to really talk about what I really think this time. But even though a lot of things have changed, one thing that hasn't changed is really kind of the energy, the passion, the commitment in this collaborative. It just seems like you just keep growing every time I see you. And the work that you do, you truly are one of the best and one of the largest, one of the most amazing collaboratives that I've seen across this country. I really want to just say thank you and kudos for the work that you led back in 2011 in really driving down early elective delivery in this country. And it's really that work that really inspired me to launch the COIN, the Collaborative Improvement Innovation Network that Dr. Lakey talked about. that brought together the 13 southern states, and Dr. Lakey played a really tremendous leadership role in that resulted in, and can I have the slides up? That resulted in, could you advance the slide for me? Oh, I have control over here. Wonderful. It's okay. That resulted in a 22% decline in early elective delivery, translating to 71,000 early elective deliveries averted across the 13 southern states. It also resulted in an increase of smoking cessation by 7%, an increase of safe sleep position by 5%, a decrease of preterm birth by 4%, and a saving to Medicaid programs across the 13 southern states of hundreds of millions of dollars. And all of that because the work that you started right here in Texas. So again, just thank you, kudos for all that you do, and just being here this morning and hearing all the tremendous work that you're doing, both in terms of what you're doing with the collaborative, from the maternal early warning system to the NICU breastfeeding, and also the work of the Texas AIM. It's just the tremendous work that you're doing. So I really just want to come here and take this opportunity to say thank you and kudos for all the great work that you do for this nation. So thank you, Texas. You really rock. Okay. And I also want to just take this opportunity to thank Dr. Lakey for your friendship, for your partnership, for all of these years, and for that very generous introduction. I do have to say that you left something out in that introduction, a very special skill that I have, which you might actually not know about, which is that I can actually time travel. You didn't know that about me, did you? Okay. So how many of you have ever time traveled? Okay. Like when you're actually sober. Well, you're in for a treat. Okay, so we're I'm going to have you come into my time machine, and let's move forward 10 years. Okay. Let's go to 2030. Okay, so you wake up tomorrow morning, you get your cup of coffee, you open up your newspaper or your iPad or whatever you're going to be reading your news on at that time. Which headline are you more likely to see? That maternal mortality just kept rising in Texas, having doubled in the last decade, and unsafe maternity care is to blame? Or that somehow you managed to turn the tide around on maternal deaths, that you cut maternal mortality in half in the past decade, all due to the work of this collaborative? How many of you think it's the one on your left? How many of you think it's the one on your right? All right. All right, well, let's go back in the time machine and let's go even farther into the future. Let's go to 2050, a generation from now. Which headline are you more likely to read? That the maternal mortality crisis continues in Texas, and now your maternal mortality is highest in the nation, and it's comparable to some of what we call developing nations, and that ugly, disgraceful gap, the racial, ethnic, the socioeconomic, the geographic disparities persist, or that you managed to eradicate maternal mortality from Texas, that you managed to achieve zero maternal deaths for 5 years in a row. According to the CDC, Texas moms and babies are now healthiest in the nation. Okay. Which will it be? How many of you think it's the one on your left? How many of you think it's the one on your right? Okay. All right, so obviously the answer is, it depends, right? it depends on what you do or fail to do, the actions that you take or fail to take in the coming decade. So these are the two questions I want to try to address this morning. Okay, what will it take to reduce maternal mortality in Texas by half by 2030? And what will it take to eradicate maternal mortality in Texas by 2050, to achieve zero maternal death in one generation? Okay. So let's start with this one. What will it take to reduce maternal mortality in Texas by half by 2030? Well, I think the answer is pretty simple, and you're actually already starting doing it, right? It's by improving the quality and safety of maternity care for all women of Texas. And that's because we know that more than half of all U.S. maternal deaths, and same thing here in Texas, are preventable. In fact, based on a CDC report, based on the maternal mortality review from 9 states, that 63% of all maternal deaths, 68% of maternal deaths due to cardiovascular conditions, and 70% of maternal deaths due to hemorrhage are totally preventable. Okay? And often it's preventable because there was a delayed diagnosis, a delayed response, or inappropriate treatment, or just poor communication and coordination across providers and systems. Now, as an OB/GYN for about 20 years, okay, I actually seen some of that firsthand. I can recall very early on in my training, being scrubbed in a case of massive obstetrical hemorrhage where it's just totally chaotic, right? You got the attending just like screaming and yelling at everybody. Instruments get flunked around, lap sponges getting lost, and everyone's freaking out. And in the meantime, the woman's just like bleeding and bleeding so much so that she's, her body's chewing up all the clotting factors and all the platelets that she's not able to clot anymore. So she's like losing tons of blood. Okay. And later on, I've also just kind of scrubbed in cases of obstetrical hemorrhage where everyone knew exactly what they were supposed to be doing. Right? So there's someone calling out time. There's someone keeping track of lap sponges and instruments. There's somebody that's designated to like run back and forth between labor and delivery and blood bank to make sure that we're keeping up with transfusion. And the attendant's conducting the whole hemorrhage as if she is conducting a symphony. Right? And everyone knew exactly what they were supposed to do, and you can save so much, prevent so much maternal morbidity and mortality if you know what you're doing. Now, of course, that's a lot harder if the first time you're actually doing it is when the hemorrhage is happening, right? And that's when kind of where the drills come in, where the simulations come in. That's where the protocols, the checklists, the toolkits, the best practices, the resources that we all package together called maternal safety bundles, which are these bundles designed to improve the quality and safety of maternity care. They're really designed to improve the 4 R's, right? Readiness, recognition, response, and then reporting and reviewing so that you can keep on getting better. 8 such maternal safety bundles have been developed, and more are actually in the pipeline. These 8 address some of the most significant causes of maternal deaths in this country. And we know these maternal safety bundles work. In fact, I actually saw them work firsthand. So I was one of the founding board member of CMQCC, led by Dr. Elliot May, whom you heard from kind of last year. And so early on, I saw a network of just super dedicated doctors, nurses, and public health professionals. We went around the state. We went knocking door to door. We went into the hospitals. We engaged hospital CEOs. We talked to OB chairs. We provide in-service for the labor and delivery staff. We did ground rounds for all the physicians, and we helped them implement these safety bundles. Okay. And then we watched the needle move in real time. Up until about 2006, California's maternal mortality just kept going on with the rest of the nation, right? It just kept climbing. Between 2006 and 2012, maternal mortality in California decreased by about 60%. It decreased by 60% in 6 years. And at the same time, maternal mortality for African American women decreased by about 50%. Okay. So when I became the director of the Federal Maternal Child Health Bureau, wanting to put the M back in MCHB, and want to make sure that the 50 states don't have to reinvent the wheel 50 times, that's when we decided to launch AIM, the Alliance for Innovation for Maternal Health. Okay. And the idea of AIM is, can we spread and scale these safety bundles to other states, to other hospitals, to try to improve the quality and safety of maternity care. So we work with 25 national organizations that's led by ACOG, as well as more than 20 states, and we've been able to spread these safety bundles into more than 1,000 hospitals all across the nation, with the idea that if we can get these safety bundles into every single maternity hospital in the United States over the next few years, we can reduce maternal mortality by about half. Okay. So can Texas reduce its maternal mortality by half by 2030? Right? Yes, we can, right? And the reason? 5 letters, like TCHMB, okay? And I probably should add like Texas AIM in there. I still haven't quite figured out the relationship yet, but yeah, like you're all in this together, right? And I do truly believe that you can do this. First of all, you got the track record, right? You were the first to lead a QI initiative that was so successful that inspired a whole national movement around early elective delivery. You got the people, you got the collaborative. I really truly believe that you can do this. Although it's not gonna be easy, right? First of all, Texas is just huge, right? You got hundreds of hospitals, and for some women in your state, they have to go 50 miles for prenatal care. They have to go 100 miles for labor and delivery, right? And one thing I also know about Texas is that top-down doesn't work very well, right? That the hospitals, the community, they're not gonna like listen to like somebody tell you what to do, right? And so that's what I'm going to avoid today. I'm not going to tell you what you need to do right here in Texas. You know a lot better kind of what you need to be doing in your hospital, in your community. But what I will do is share some of the lessons I learned from kind of working with Perinatal Quality Collaborative for about a decade now. Okay, and not that I have all the answers, but just because the role that I play, I've worked with all different perinatal collaboratives, and I've seen some collaboratives succeed, and I've seen a lot of them just flounder, right? So what makes some of them thrive while others fail? So what's the secret sauce to successful perinatal quality collaborative? Okay, so I will highlight 5 key ingredients to that secret sauce, which is leadership and co-ownership, coalition building and collaborative learning, accountability, early wins, and then creating that culture of quality and safety. Starting with leadership, right? Leadership truly matters. In every successful state, I can literally point to a charismatic leader who took charge of the quality initiative, right? So in California, it was Elliot Main. In Louisiana, it's Rebecca Gee. In Texas, with regards to early elective delivery, it was David Lakey. Right? Now, of course, David would be the first one to tell you, no, it takes a team, it takes a village, right? But leadership does matter, right? And you do know, kind of need that leader who knows how to lead change, how to create a sense of urgency, how to form a powerful coalition, how to create a vision for change, how to communicate that vision, empower action, create quick wins, building on the change, and ultimately making this step, creating the culture of quality and safety in hospitals, in communities, in state, across the state. Okay. Well, if leadership matters, co-ownership matters even more, right? And Elliot and David and Rebecca, they will be the first to tell you that they can't do the work on the ground where the rubber hits the road, right? So you really need that leadership at the community level, at this hospital level, someone who's willing to step up and take charge. Now, that somebody doesn't have to be the hospital CEO, that someone doesn't have to be the perinatologist or the OB chair, right? But it really needs somebody who, with or without a formal title, but has the ability to bring folks together to really kind of lead the quality initiative. And that's why I kind of really love the theme of this conference, to making quality improvement local, because you really get quality improvement, right? It really needs to be owned locally. But I think that's also why the challenge for Texas is because you have such a big state. Is how do you spread and scale QI to these smaller, low-volume rural hospitals where the staff is already overworked and under-resourced? But again, all you need is to engage a leader on the ground who's willing to step up and really take charge, and that's how you can get that started. The second thing, the second element is around coalition building, right? And any successful collaborative really require broad-based coalition. So the question is, do you have the right people at the table? So at the local level, at your kind of hospital or community level, in addition to your usual suspects, the OB and peds, docs and nurses and so forth, do you have the anesthesiology on board? Do you have folks that are working on informatics and vital statistics, folks that are doing administration, board members, families, communities? And at the state level, do you have, in addition to hospitals, do you have payers, accreditors? Do you have the Title V programs, your public health folks, with you, the policymakers? And very importantly, do you have family voices represented in your coalition? Now, once you bring all of these different folks on board, what are you doing to maximize collaborative learning? So at the local level, when you have a collaborative meeting, are folks just kind of dragging their feet, or are they actually excited about coming to learn from each other? Right? And at the state level, when you have an opportunity to bring folks together like this, are they just kind of being talked at, or do you have kind of building plenty of opportunities for folks to share to share best practices and lessons learned? Okay? And again, a challenge for Texas, because you're so big and you have so many hospitals, how do you keep partners actively engaged in a large collaborative? And I think I learned this lesson the hard way when we were doing the coin. When it was just the 13 southern states, it was actually pretty easy, right? When the 13 states got on the phone, we could actually go down the list, go down the roster, right, state by state, and each state present their data. They talked about what's working, what's not, and people are able to share lessons learned and best practices, so forth. And then we got greedy, and then we decided to go national. We went from 13 states to 50 states. Okay? And then all of a sudden, when folks get on the phone, you can't share data, you can't share lessons learned that way anymore. So we started having all of these presentations by experts talking about QI topic, and right away, we turn these active learners into passive participants, and some folks actually stopped. Some states stopped submitting their data, and they really stopped sharing best practices and lessons learned, and then I can just watch the coin start to implode, right? And so that was a pretty hard lesson learned, and I still haven't quite figured out, when you have to do it at this scale, how do you maximize collaborative learning? And one key question is always to think about your end users, right? What's the value add when you bring your end user, when you bring the hospitals, when you bring communities together? If you're trying to design a learning system that can maximize collaborative learning, what are you actually doing to really support that, to maximize collaborative learning for these end users? So bring some design thinking into designing your learning system. The third thing is about accountability, right? And accountability is all about measuring and delivering results. It's all about being able to answer these three questions. What are we trying to accomplish, which means having clear goals and SMART objectives. Objectives are specific, measurable, achievable, realistic, and time frame. How are we going to accomplish it? Which means having clear strategies that are informed by the best science and best evidence. And then what will success look like? Which means having clear metrics and real-time data, right? And that the metrics need to be meaningful and feasible, and data must be transparent and real-time, right? You need real-time data to know what's working and what's not, to have real-time data to drive real-time improvement. And I think another thing that's really important, you need to be able to create that safe space for data sharing, for people to like look at each other's data and say, hey, what are you doing there that I'm not doing that's helping you achieve the outcome that you're demonstrating. And that's why over the last few years, whenever I got called into congressional offices, when legislators are drafting bills and so forth, they always want to put in that public reporting data in there. And I always advised against it because I think it just has a way of potentially undermining that safe space, undermining that trust and credibility that we're trying to build with these learning collaborative that people can safely share data and learn from each other's data. And I can't overemphasize the importance of having these early wins. Okay, so you need to secure early win in any QI projects that you're doing in order to establish credibility, to generate momentum, to recruit supporters and convert skeptics and disempower cynics. And then that means that you have to pick your early win strategically. That the win needs to be quick. Okay, usually I would say probably in the 18 to 24 months period. Visible, unambiguous, and meaningful. To tell you the truth, when David and his fellow state health officials from the 13 southern states elected to have early elective delivery as the first project that y'all want to work on for the coin, I was actually not very excited about it. And the whole idea is that I didn't think the early elective delivery wasn't going to really go that far in terms of addressing infant mortality in this country, but I have to be true to what I was saying in terms of that co-ownership, right? To respect what you're doing on the ground, and if that's what you're truly passionate about, HRSA was go all in behind you in terms of supporting that work. Well, it turned out to be the most brilliant strategy. Right, because it created that early win that really emboldened us to do a lot more because it was quick, that we saw results in about 24 months, that the win was visible and unambiguous, right? We saw a 22% reduction in early elective delivery translating to 71,000 early elective deliveries averted, and it was meaningful, right? Because especially for our stakeholders, the governors, the state health officials, the Medicaid directors, it saved hundreds of millions of dollars from state Medicaid budgets across the 13 southern states. So that provided such incredible early win that inspired folks to say, all right, well, if we can do this, let's go bolder, let's go more transformative. And we are having multiple coins that emerged as a result of that first coin, and there was even a coin on social determinants. Obviously, we weren't going to see results in terms of an early win from social determinants in 18 to 24 months, but having this early win under our belt really helped build up that momentum and that belief that we can move the needle. And then lastly, as to create a culture of quality and safety. And culture is just a way of life, a norm of behavior. So we want to make sure that you actually create that organizational culture where quality and safety is everyone's responsibility. Okay. And this is where there's a lot that we can actually learn from the Toyota production system. That's the underpinning of the lean management system. And there's one principle about stopping the line where every employee on the assembly line has the responsibility to push big and red button that stops everything whenever they notice a defect on the assembly line. Okay. So the whole idea about creating that culture of quality and safety is that you want to be able to empower all of your staff, and whether it's a receptionist at the front desk, whether it's the charge nurse or a postpartum kind of nurse, you want to make sure that each and every one of them, if they see an adverse event, if they see something that could be improved, that they are empowered to speak up and do something about, so that you turn your hospital, you turn your into an improvement organization that you know you're doing good, but you can always do better. And that's when that's how you start to really transform your organization into an improvement organization. So those are the 5 ingredients that I've observed in terms of that secret sauce for a successful perinatal quality collaborative. It's nothing that you don't know or you haven't seen already, but just kind of worth underlining that leadership and co-ownership matters, expanding coalition building and maximize collaborative learning, promoting accountability, securing early wins, and then creating that culture of quality and safety. Okay, so that's like half of the story, right? But if we're talking about in a generation eradicating maternal mortality from Texas, right, achieving 0 maternal deaths by 2050, I don't think we can QI our way to 0 maternal deaths. Right? There's just a lot more things that we need to do. Okay? So what will it take to eradicate maternal mortality in Texas in the next generation? Let me just open it up and see, any thoughts about what we can do, what you all can be doing in addition to quality and safety? What can you be doing to eradicate maternal mortality in Texas by 2050?
Cultural competency.
What's that?
Cultural competency.
Cultural competency. Community involvement. Addressing systemic racism. Expand health insurance coverage.
Integrate midwives.
Integrate midwives. Partner with patients and families. Addressing poverty. All right, my talk is done. You got it all. Okay. Right. So I'm glad that's the direction we're taking this conversation, right? Because I do think that it's going to take a lot more. QI will take us halfway there, but the other half, that's where the hard work begins, right? That's where we really have to dig in and really think about what we have to do to eradicate maternal mortality in Texas. And simply, you got to start to improve the health of girls and women in Texas all across their entire life course. So these are the 5 biggies that stand out for me, but certainly I think some of the other things that you mentioned are just as important, right? So we need to assure healthcare access, we need to transform healthcare, we need to reduce chronic stress, we need to address social determinants, and we need to promote health in all policies. Starting with assuring healthcare access, not only during pregnancy, but before pregnancy, between pregnancy, beyond pregnancy, and really across the entire life course of women and families. And that's especially important in the face of the changing demographics of childbearing, both here in Texas as well as across the United States. Women are getting older, they're getting sicker when they become pregnant. A lot more women are now entering pregnancy with many more chronic conditions like diabetes, heart disease, hypertension, and obesity, which put their pregnancies at greater risk, right? And there's some real limits in terms of what we could be doing during prenatal care to address these chronic conditions, that we just cannot cram all the fixes into less than 9 months of prenatal care and then expecting everything to turn out all right in the end. And that's why we OBs have been like pushing this whole idea of preconception care really hard for the last couple decades. And again, kudos to what you're doing around the one key question, right? The one key question is, would you like to become pregnant next year? And if the answer is no, then that should be a gateway to reproductive life planning and contraception, and if the answer is yes, then that should be a gateway to preconception care, making sure you get your blood sugar under control, making sure you get your blood pressure under control, making sure you get off teratogenic medications, and making sure that we're doing everything we can to really optimize women's health before they get pregnant, which will go a long way toward improving pregnancy outcomes in the States. But even then, given everything that we know, both in terms of life course influences and developmental origins of health and disease, including their future reproductive outcomes, that one visit 3 months preconceptionally is still going to be too little too late. So ultimately, assuring access to comprehensive women's health services across the life course is what we really need to get us closer to achieving zero maternal deaths in the state and across the country. That said, guaranteeing universal access to a broken healthcare system is just not going to get us very far, right? We spend, as a nation, we spend more than any other nation on perinatal care, and yet we rank near the bottom among developed nations on most standard measures of perinatal outcomes. And that's because our perinatal care system is truly like broken, right? It is limited, it is episodic, it's inequitable, it's fragmented. And so in this report that came out this last year from the National Academy of Medicine that I was on the committee, we made a strong argument for the need to radically transform preconception, prenatal, postpartum, and pediatric care in this country. So let me give you an example of what that might mean for prenatal care. This is just kind of a thought exercise. Okay, so how we deliver prenatal care today, I think I feel like it's still like very much like stuck in the 1980s. Okay, so, the software may have changed, but the hardware, how we actually deliver prenatal care, it's not all that different from when I was trained back in the 1980s, right? And still very much kind of centered around the prenatal visits, the clinic visit, the 10, 15 visits that are recommended for all pregnant women, which means for most low-income women, that means taking unpaid leave from work, arranging childcare, taking multiple buses to go and sit and waiting in the waiting room for an hour, 2 hours or more for that 5-10 minute visit, during which you get one spot blood pressure check, okay, one spot urine dip, a quick listen to the baby's heart tone, and a quick measure of the fundal height, which is like totally inaccurate. And then just a hurried conversation with a provider who, despite best intentions, just neither has the time nor the training to like really talk to you about self-care, let alone addressing all the important issues around psychosocial stress or occupational or environmental exposures. So that's prenatal care in the 21st century. Is that really the best we can do for moms and babies in the 21st century? So as a thought exercise, okay, what if instead of kind of bringing women to prenatal care, what if we can bring prenatal care home to the women? Right? And what if we're able to actually collect all of that information that we collect in a 5-10 minute visit at home, okay, with all the wearable sensors, lap on a chip, on a more high-quality data on a more continuous basis, and not just all the gimmicky, gadgety stuff, right? But the things that we know are actually truly important to not only the pregnancy outcomes, but to developmental origins of health and disease. Things like nutrition and physical activities, stress, sleep, occupational and environmental exposures. And what if all of these information can be then fed to the cloud, and through like AI and machine learning, you can actually develop better algorithms, better predictive analytics to determine which women would be at greater risk. And then you can actually tailor your prenatal care to the needs of that woman, so you can triage women to say, all right, she actually needs a call from a health educator today, or she needs a home visit tonight, or she should come in and see the specialist tomorrow. So instead of like one size prenatal, one size for all prenatal care, we start talking about the right care for the right woman under the right circumstances toward more precision prenatal care. Now, I don't want to get carried away with all the gadgets and technology and stuff, right? Because this isn't all just about high tech, but what high tech might allow us to do is to allow for more meaningful high touch, right? So what if we can bring the whole design thinking into this, and we can redesign prenatal care not around the needs of the physicians or the clinic hours or the efficiency of the system, but really around the needs of women and families. So what if we were to then, instead of bringing them for that 5-10 minute hurry visit, use it as an opportunity for health education or group prenatal care, so that we can marry both high tech and high touch. Right? It seems like that those are the type of conversations that we really need to be having in this country to truly rethink how we deliver preconception, prenatal, postpartum, and pediatric care if we really want to move the needle. And honestly, that is one of the unfinished work that we started at the Bureau. I think getting people access to healthcare is the first step, but it's not the final step. That there's still so much work that we could be doing to move the needle on maternal and child health in this country by truly transforming the healthcare system. All right, and let me just also take a minute to talk about chronic stress, because I do worry that we're really not going to move the needle in terms of women's health or advancing health equity if we don't talk about the chronic stress that's really becoming a way of life for so many women in this state and in this country. Right? And whether we're talking about the stress of having to juggle between childcare and elder care, or the stress of having to juggle between work and family, the stress of having to work multiple jobs just to make ends meet, or the stress of just having to put up with violence and trauma and sexism and racism. And I think our society is just putting so much stress on women, especially poor women and women of color, that it's really making them sick. Now, when I was a medical student, we didn't talk a whole lot about stress because stress was considered a soft risk factor. Right? But thanks to all the scientific research over the last several decades, we're now beginning to get a better understanding of how chronic stress can get under the skin to create wear and tear on your body's organs and systems that may cause chronic disease, and then when you become pregnant, that may lead to adverse pregnancy outcomes. And how does that happen? Well, what does stress do to your body? What happens to your body when you see a saber-toothed tiger? Okay. You run, right? And what helps you run faster, your body activate that whole fight or flight response. You activate the hypothalamic pituitary adrenal axis and the sympathoadrenal medullary system. You're putting out all of these stress hormones to help you run away from the tiger. Okay. Now, what happens after you got away? Your blood pressure comes down, your pulse comes down, and you relax. Right? And that's the amazing thing about the human body, is that it's self-regulating. It knows how to shut itself off once the stressor has been removed. And that's what we call allostasis, okay, which means to maintain stability through change. To maintain stability through change. And allostasis works largely by a negative feedback mechanism that's common to many biological systems. It works very much like a thermostat. Okay? So let's say the temperature in this room falls below a preset point. What happens? The thermostat kicks in the heat, right? But as soon as that preset point is reached, what happens? The heat turns off the thermostat to prevent this room from being overheated. Right? So the same thing actually happens inside your body, that when you're under stress, your body activates the HPA axis to produce cortisol. Cortisol, in turn, negative feeds back onto the brain to shut off the HPA axis to keep your stress response in check. Okay? So that's allostasis at work, maintaining stability through change. So allostasis works really well for stress that you can either fight off or run away from. Okay? But what happens if you can't get away? What happens if there's nowhere to run? Well, you get eaten, right? But if you don't get eaten, what happens? Okay? In the face of chronic and repeated stress, your body loses that ability for self-regulation, so now you can turn on, but you can't shut it off. Biologically speaking, what may be happening is you get this tonically elevated level of cortisol, which start to downregulate glucocorticoid receptors in your brain, so you'd start to lose that negative feedback. And so with that, we find in animals and in women who are under chronic stress, they actually walk around with higher circulating levels of stress hormones. And if you were to subject them to some natural or experimental stressors, that they would put out a lot more stress hormones than people naturally would. And that's when you start to go from being stressed to being stressed out. Okay? And wow, it's getting stressed out. Nice job back there. And there's actually a big difference here, right? It's a difference between protection and damage. Because under acute stress, your body activates a sympathetic response to increase your cardiac output, the amount of blood that gets pumped out by your heart every minute, okay, to help you run away from tiger. But when you're stressed out, you can't shut off that sympathetic response, and that chronic, uncontrolled sympathetic activation over time is going to lead to hypertension and cardiovascular diseases. Under acute stress, as we talked about earlier, your body kicking the HPA axis to produce cortisol. And cortisol is a glucocorticoid, and one of the main functions of glucocorticoid is it actually converts your body's stored energy into glucose, which then becomes a readily available fuel, again, to help you run away from tigers. Right? And it does that partly by impeding your insulin action. But under chronic stress, all that, you can't shut off the HPA axis, and all those excess glucocorticoids over time will lead to glucose intolerance and insulin resistance. Under acute stress, your body's immune functions actually work better. But as most of you know, under chronic stress, you become a lot more susceptible to infection and inflammation. And the way to think about this is to think of the relationship between the HPA axis and the immune system. Think of it as the HPA axis as a set of brakes on the immune system. Okay? So if you're chronically stressed out, okay, that's like driving with your foot on the brakes, right? So what happens when you drive a car with your foot on the brakes? You hate to drive behind people who drive like that, right? So the car just doesn't run very well, as in the case of depressed immune function, okay, and increased susceptibility for infections. And that's why we have lots of studies that show that women who are under chronic stress are more susceptible to infections, including things like bacterial vaginosis that could increase your risk for preterm birth. Okay? But what's going to happen over time if you keep driving with your foot on the brakes? You're going to wear out those brakes, right? And now you have a much bigger problem, as in that you can't stop the car, okay? As in runaway inflammation, right? And think of all the chronic diseases that are characterized by excess runaway inflammation. Hypertension, diabetes, heart disease. Okay? And think of all the health conditions that are characterized by a great deal of health disparities. Okay? Lupus, nephritis, autoimmune diseases. So the question is, do you think chronic stress may actually play a role in the pathogenesis of chronic diseases and in the origins of health disparities in our society today? And lastly, when you're under acute stress, you actually get growth of neurons in the hippocampus and the prefrontal cortex. These are learning centers inside your brain. So almost if it's there to help you learn from your mistakes. Right? But under chronic stress, the exact opposite happens. Okay? So rather than growth, you get atrophy and death of neurons inside these learning centers. Okay? And that's why women who are under chronic stress begin to report that they're becoming more forgetful, that they're losing their memories. I think Bruce McEwen at Rochester University provides perhaps the best illustration of these concepts of allostasis and allostatic low in this cartoon here. Okay? In this in this bottom image here, you got two kids balancing on a seesaw. Okay? That's a picture of allostasis, right? Maintaining stability through change. Okay. But what if I were to replace these two 5-kilogram kids with these two 500-kilogram sumo wrestlers? You put so much stress and strain on that seesaw that sooner or later that seesaw is going to break. Okay. And what if a woman were to enter pregnancy carrying these two 500-kilogram sumo wrestlers on her back? She's not going to have a very good pregnancy. And remember, pregnancy itself is a major stressor on the body, and so that a healthy woman can handle the extra stress, but a woman with organs and systems that are kind of worn out by chronic stress will have a much tougher time. So I was part of a National Academy of Medicine committee that put out a report on rethinking the causes and prevention of preterm birth about a decade ago. And I remember kind of during committee meetings, we had a lot of discussion about the need to rethink the causes and prevention of preterm birth. Okay. And that's because we used to think that preterm birth was the consequence of some precipitating event like an infection or a stressful life event that occurred right around the time of the onset of labor. But we now think that the origin of preterm birth may occur much earlier than that. That our vulnerability to preterm delivery may be traced to not only exposure to stress and infection during pregnancy, but perhaps more importantly to host response to stress infection. And it's the stress reactivity inflammatory dysregulation that I was describing early that's been patterned over the life course. Okay. So if we want to prevent preterm birth in this country, what do you have to do? It's a pretty simple message here, right? We've got to start taking care of women not only during pregnancy, but long before they get pregnant. And a very important objective of preconception care has to be to restore allostasis and optimize women's health before they get pregnant. And let me just say a little bit about kind of the social determinants, because certainly a major source of chronic stress in women's lives are all these social determinants, right? It's the air we breathe, the water we drink, the food we eat, and most important, the social conditions in which we live, work, play, and grow old, right? And there are studies after studies that shown that social determinant of health really accounts for up to like 75% of population health. Medical care is a social determinant, but you can see in these studies, medical care account for about 20-25% of population health, and that's why people think that whereas in the U.S. we invest so much on healthcare that other countries may have better health outcomes because they choose to invest in creating better social ecology for their citizens. I think what's important to think about is to like really start taking this conversation beyond just healthcare, right? So a few years back, my colleagues from around the country and I decided to just put forward this 12-point plan to close black-white gap in birth outcomes. We did it not because we had all the answers, but we just want to provoke a different conversation about what we need to do in this country to really advance health equity and address disparities in this country. I'm not going to go over all 12 points, but just the first 4 points about interconception care, preconception care, quality prenatal care, and expanding healthcare access over a life course move us beyond our current focus on prenatal care to addressing the healthcare needs of women and families across their life course. The next 4 points about strengthening father involvement, enhancing service coordination, creating reproductive social capital, investing in community building, move us beyond our current focus on trying to change individual behavior to working on strengthening family and community systems. And then the last 4 points around closing education gap, reducing poverty, supporting working women and families, and undoing racism, again, move us beyond our current focus on the medical model to start addressing the social and economic inequities that underlie much of our health disparities. I'm going to just, I know I'm kind of running out of time, so let me just kind of address one more thing, kind of the elephant in the room, which is racism. And we certainly have growing data that show that racism plays an important role in health outcomes. There are tons of studies like this now. This is one of the first studies where my colleague Jimmy Collins and colleagues showed that the experience of racism in 3 or more domains of life across your life course increase your likelihood of having a very low birth weight baby by about 3-fold. Okay? And that's just interpersonal racism. Right? What about institutionalized racism? Okay. Some of you may be familiar with the work of Dr. Kamara Jones, who's the former president of APHA, and Dr. Jones talked about 3 different levels of racism: internalized, interpersonal, and institutionalized. Right? So internalized racism is when the racism is so pervasive that women of color come to see themselves as inferior. Okay? Interpersonal racism is the kind of racism that we all think about when we hear about racism. Right? It's about the unconscious bias and the conscious discrimination. Right? And then there's another level of racism that's perhaps more pervasive and perhaps more pernicious, and that's called institutionalized racism. Okay? And that's defined as differential access to goods and services that society has to offer based on your race. Right? Differential access to goods and services society has to offer based on the color of your skin. And Dr. Jones then offered this very powerful allegory to illustrate these 3 different levels of racism. She said that in this garden, there are 2 flower pots. Okay? A flower pot, in the flower pot with rich and fertile soil, the gardener planted seeds for red flowers. And in the flower pot with poor and rocky soil, the gardener planted seeds for pink flowers. So over time, guess which flowers grew better? The red flowers, right? And then in time, the flowers passed the same seeds into the same soil. So generation after generation, the red flowers flourished while the pink flowers just languished, struggling to survive. So how do you get things right in that garden? Well, Dr. Jones says that it's probably not enough just like to sit down with the pink flowers and tell them that pink is beautiful, right? And it's probably not enough to like sit down with the gardener and so I said, you should like really try to treat the pink flowers a little better, right? Try to do some cultural sensitivity, cultural competency training, right? Not that that's not important, but it's not going to fix everything, right? So what do you have to do in that garden? Yeah, 2 things. You either mix the soil or you enrich the soil in the pink flower pot until it is as rich and as fertile as the soil in the red flower pot, right? And that's really kind of what we're all talking about here. We're talking about enriching the soil with good health care and good education and good housing and good opportunity, ensuring those conditions in which every child, every woman, every family can thrive in this country. Right? And that's what we have to do if we really want to get to that point of zero maternal deaths in the next generation. So I'm going to just kind of go through, obviously, some of this you can't fix downstream, right? As much as we like to think that we can fix all MCH problems with MCH program services, to like really tackling the root causes of some of our biggest problems, some of the most deeply rooted health disparity will require social, political, and policy change, and we really have to kind of take the work kind of upstream. So let me just kind of finish with one personal thought about our work in maternal and child health. Ultimately, I think all of this that we're talking about today, whether it's infant mortality, whether it's maternal mortality, these are, to me, these are really not just an accounting of maternal or infant deaths. And these are not only indicators of community or population health. Ultimately, these are the measure of how much we fail the greatness of this nation. And it's a greatness that was summed up in the proposition some 250 years ago, that we hold these truths to be self-evident, that we're all created equal. It's a greatness that's made with a simple promise that right here in America, everyone gets a fair shot, no matter where you're from, or the family that you're born into, or the color of your skin. And it's a greatness that's told many times over every single night. Okay. When we tuck our children in bed, that we tell them that when you grow up, you get to be anything that you want to be. It's really a greatness that I didn't just read in the book or learn in the classroom. I saw it and lived it, perhaps like many of you. So those of you who know my story know that I was born to two immigrant parents who never went to college. In fact, my mom never went to high school or even junior high. See, my mom was only 11 when her father died, so as the oldest daughter in the family, she had to drop out of 5th grade to go work in the factory to help support the family. And when my parents got married, they were still pretty poor. The home that I was born into is a tiny little apartment on the other side of the tract in Taipei where a family of 6 was crammed into. No flush toilet, no running water. And unfortunately, I was sick quite a lot as a child, and there weren't such things as health insurance back then. So whenever you get sick, you never knew how much the doctor or the medicine was going to cost. And from time to time, my parents had to make that difficult choice between paying for food and paying for medicine. And at one point, my mom sold her wedding ring to pay for my medicine. So obviously, I didn't come from an educated family or a wealthy family. But none of that mattered anymore once we came to this country. Because I knew that in a great America, you don't have to be rich to go to the best schools. And in a great America, everyone gets a fair shot, no matter where you're from, or the family you're born into, or the color of your skin. And in a great America, I knew that if I just work hard enough and try hard enough, I can give my 2 daughters a better life, the kind of life that my mom couldn't even dare dream of. And that my two girls, the granddaughters of girls who had to drop out of 5th grade to go work in the factory, can now grow up in a nation where they get to be anything they want to be. That's what truly makes America great. Truly what makes America great. But if my girls can get that chance, why shouldn't every child in America get the same chance? If my girls can get a fair shot, why shouldn't every child get a fair shot? So this is what our work in maternal child health is all about, right? This is a lot more than just a fight against maternal mortality or infant mortality. This is a fight for who we are as a nation, as a people. This is a fight for a version of America, a vision of America that we love, that we still believe in, that we wanted for my children, your children, and all of our children. Now, you and I, we might not get there ourselves, but we're going to keep working, and we're going to keep fighting, and we're going to die trying so that someday our children and their children will get there to a more perfect union. Thank you very much.
We're a little bit over time, but I'm going to take 5 minutes so we can have questions. And again, you can see how thrilled I was to have Michael Liu here. And so I want to take advantage of this opportunity. And if people have questions, we're going to spend 5 minutes. We can still get to lunch in time, still get back to the 1:30 work sessions. But are there any questions right now? I have a question right over here.
Good afternoon. Thank you, Dr. Liu. It's an absolute pleasure to see you and hear you present again. My name is Eulalia Gillum, and I am with the University of Houston's Healthy Start Project in Houston, Texas. The question that I have for you, based on some of the slides and the information you presented today, as great of a state as Texas is, what are some of the lessons can we learn from the state of California and the work that it's done to improve birth and health outcomes for mothers and babies?
What was that, Doctor? Was it Dr. Spears that said something about this competition between California and Texas earlier this morning? Well, first of all, let me just say you are already doing quite a lot, right? Both the collaborative that you have, as well as the Texas AIM and your ability to bring so many hospitals together to work on quality and safety to make sure that all women of Texas in Texas, all women of Texas have access to quality, safe maternity care. That's going to go a long way. Right, so it's going to be just a matter of time before we start to see the needle move in real time as we did in California. I think you're doing all the right things there. What I haven't heard as much is what about all these other things that really need to happen. Fortunately, over the years, I've worked quite a lot with the Title V program. I've worked with the Healthy Start program in Texas. I work with home visiting programs in Texas. And I think that's also just as important, if not more important, parts of the solution in terms of like really addressing both maternal and infant mortality in Texas. And kind of make sure that as much as you're like driving quality improvement in hospitals and in clinics and so forth, to make sure that you continue to pay attention to social determinants, to where people live and work and grow old, and to make sure that you create the social conditions in which all women, children, and families can be healthy.
Thank you very much.
One more question? Why don't we get two? One here and then we'll answer questions on the side afterwards.
Hello, my name is Rosalind Cooper. I'm a full spectrum doula here in the Austin, Texas area. So you talked about social determinants of health and improving maternal mortality and improving maternal child health, not just in a clinical setting, but also in a social setting. ACOG has now said for a few years that doulas improve birth outcomes. At what point do we really start pushing that conversation with institutions of healthcare to include doula care and doula support in the clinical and into the community health setting?
And really, that's kind of why I wanted to kind of bring in the whole kind of discussion about chronic stress and social determinants, because I do think that when we're talking about team-based care, doula has a very important role to play, right? And I don't know kind of Texas health system kind of well enough to know what are the policies and regulations and reimbursement and so forth that may kind of stand in the way. But if you think that doulas are an important player, then let's figure out the system and the policies and regulations in such a way to like really enable that teamwork.
Thank you, sir.
First of all, Dr. Lakey, thank you so much for bringing Dr. Liu. And, you know, Dr. Liu's been here for so long. He's like an honorary Texan to us. and he really, you know, because we have to think like a Texan type of person. He's like our star quarterback and so forth. I'm not going to name a specific one because we have more than one football team in Texas. But really, the point I really want to ask you about is, I think that most of us, we may or may not recognize it, but we do have some implicit unconscious bias. How can we do better in terms of individual level, department level, community level, just be more aware and intentional about maybe reaching out to people that we normally might not reach out to mentor and to bring them in areas of leadership and really make a difference, because I think that's where it needs to come from.
Thank you. No, I think this is where leadership makes a difference. Leadership sets a tone. Okay, leadership creates culture. And so many of you are in leadership roles in your community, in your organization, whether you have a formal title or not. You are opinion leaders. You are organizational leaders to the extent that you can really call out the need to address the unconscious bias, the systemic racism that's even in healthcare that leads to kind of the disparities in the inequality that we see, right? Now, I think that's a kind of really important job of the leader. There are certainly a lot of trainings out there that organizational leaders can bring in to make sure that your entire workforce is aware of what's going on, and that even the kind of day-to-day microaggressions and unconscious biases that even your own staff of color may face in your organization, make sure that you set the personal example, you set the tone that this is important. We're not just going to talk the talk, we're going to walk the walk, and let's make sure that let's be that be that organization that truly exemplify how we tackle racism in this country.
I think that's a great point for us to end on. And again, thank you, Dr. Liu, for traveling here and being here with us today.